Hi everybody, my name is Kimberly Reyes and I will be talking about childhood psoriasis, specifically affecting those 0 to 12 years of age. Because of the age group, my target audience would be my fellow pediatric dermatology nurses. Childhood psoriasis, it's more than just skin deep. So, let's get started. So, what is it? Psoriasis is a chronic, incurable, non-contagious disease of the immune system that appears on the skin. Psoriasis appears on the skin as dry, red, scaly, itchy plaques. In more severe cases, psoriasis can affect the joints, causing agonizing joint pain. According to the National Psoriasis Foundation, it is the most common autoimmune disease in the United States. It affects as many as 7.5 million Americans, and approximately 40% of adults with psoriasis report the onset of their disease occurring in childhood. Approximately a third of patients report the onset of psoriasis before 16 years of age, and if the onset occurs before age 2, it is termed infantile psoriasis. So, psoriasis appears on the skin as red or white, dry, scaly, flaky, itchy, thick plaques. Up to 30% of people with psoriasis also develop psoriatic arthritis. Psoriatic arthritis is a form of arthritis that can cause agonizing pain, stiffness, and swelling of the joints. Psoriatic arthritis can also induce nail psoriasis by affecting the connective tissue between the tendon or ligament and bone, causing nail dystrophy, which is basically abnormal nail growth. So psoriasis most commonly affects the elbows, knees, buttocks, back, and scalp, but really it can affect anywhere on the body. Although the exact cause of psoriasis is still unknown, it does have familial genetic tendencies, which is non-modifiable. The red scaly plaques that are associated with a psoriasis are caused by T-cell mediated chronic inflammation of the skin causing hyperproliferation of keratinocytes. A T-cell is a type of lymphocyte that is produced by the thymus gland and actively participates in the immune response. Lymphocytes, which is a subtype of a white blood cell, play a central role in cell-mediated immunity. In psoriasis, the life cycle of skin cells are affected as cellular proliferation is significantly increased, causing cells to build up too rapidly on the skin surface. The process of skin cells growing on the innermost layers of the skin and then rising to the surface typically takes weeks. But with psoriasis patients, this process occurs only over 3 to 4 days. This causes buildup and thickening of the dermis and epidermis as dead cells cannot shed fast enough. Although hereditary factors are considered non-modifiable, there are modifiable factors that can help prevent flares and triggers of the disease. Environmental triggers initiate disease activity in young children. The more common triggers in childhood are an upper respiratory tract infection, pharyngitis, stress, and trauma. Streptococcal infections in the upper respiratory tract, such as tonsillitis and strep throat, are known to trigger psoriasis in children and young adults as well. Infectious rhinitis, or the common cold, is a common viral upper respiratory infection. The transmission of the infection is through close physical contact with the virus, such as shaking hands, and surfaces, such as touching infected doorknobs and telephones. Transition may occur through both inhalation and physical contact. Hands are virally contaminated 60% of the time, and people in closer contact with other people are at higher risk for developing the infection, such as daycares. And it is general knowledge that children enrolled in daycares get sick often. The exposure to these viral respiratory infections can then trigger psoriasis in genetically predisposed children. To avoid these triggers, hand hygiene is extremely important, as is covering one's mouth when coughing or sneezing, and utilizing face masks when appropriate is beneficial in helping to control viruses from spreading. Additionally, parents should also be educated that sick children should stay home so that other children are less likely to contract an illness. You know, these simple steps can really help avoid unnecessary triggers and flares of the skin condition. So now let's talk about primary, secondary, and tertiary interventions. So first off, primary prevention aims to prevent disease before it even occurs. Secondary prevention aims to reduce the impact of a disease that has already occurred. And tertiary intervention aims to soften the impact of an ongoing illness that has lasting effects. So for primary interventions, the goal is to prevent disease before it even occurs. Although having psoriasis is hereditary and genetic, there are things that one can do to prevent flares and triggers of the disease. These would be very similar to the modifiable pathological slide. You'd want to avoid environmental triggers that could initiate disease activity in young children. The more common triggers in childhood are, again, upper respiratory tract infection, pharyngitis, stress and trauma. Others include tonsillitis, strep throat, and the common cold. In young children, because transmission of the infection is through close physical contact with the virus, viruses are often spread by hugging, shaking hands, sharing sippy cups, sharing toys that are infected with the virus. So with children, hands are virally contaminated, again, 60% of the time. And so this is why it is so important for sick children to stay home from school or from daycare if they're sick. Otherwise, the exposure to these viral respiratory infections can trigger psoriasis in genetically predisposed children. So to avoid these triggers, hand hygiene is, again, extremely important, as is covering one's mouth when coughing or sneezing, and to utilize face masks when appropriate. This will be beneficial in helping to control viruses from spreading. So again, with secondary prevention, the goal is to reduce the impact of a disease that has already occurred. Treatment of psoriasis often includes topical emollients such as Hydrofor, Aquaphor, Vaseline, CeraVe, and Cetaphil. And as a side note, the greasier the better. Like Hydrofor and Aquaphor and Vaseline is very greasy. Also, you want to apply these topical emollients like literally within 2 minutes of from taking a shower or getting out of the bath. At our facility, we have this to lighten the mood, we say it's a like in football, the 2-minute rule. As soon as you step out of the shower, apply your emollients and all of your topical medications within 2 minutes, so that way you're kind of like locking in the moisture, and you're going to get a better benefit from the emollients. Topical steroids include triamcinolone, fluocinolone, and clobetasol. Oral medications such as methotrexate can be beneficial. Phototherapy, which is light therapy, and biologics such as Humira, Enbrel, and Stelara. So for those of you who don't know what phototherapy or light therapy is, it involves exposing the skin to ultraviolet light on a regular basis and under medical supervision. Ultraviolet light is an effective treatment for psoriasis as it penetrates the skin and slows the growth of affected skin cells. Now, with phototherapy, consistency is very, very key. For maximum benefit and to achieve faster skin clearance with phototherapy, it is recommended for patients to consistently receive light therapy 2 to 3 times a week for a duration of at least 3 months. So those affected with psoriasis should always ensure they avoid irritants that can further exacerbate their condition. Tertiary interventions would include avoiding harsh cleansers and perfumes, especially hand sanitizers, which are alcohol-based, as they are extremely drying and irritating to the skin. When showering, one should avoid vigorous or harsh scrubbing, such as with a loofah, which can also worsen the symptoms of psoriasis by aggravating the skin. Also avoiding aggressive scratching thickened plaque areas, as this can cause increased irritation to the skin. Plaque psoriasis can be itchy, but there are topical treatments that can alleviate symptoms of itching. And also keeping your skin moisturized with those emollients in our previous slide, such as with Aquaphor, Hydrophor, or just utilizing the topical medications, that would really help control any itching that one may have. As mentioned in the previous slide, one should avoid aggressive scratching plaque areas, as this can cause increased irritation to the skin. With babies, it's hard to instruct them to not scratch. So, as you know, you can use mittens or tight socks to place over their hands. I personally prefer long, tight fitting socks over the hands. They seem to stay on longer, and it's, harder for babies to pull them off. Doing this will really help prevent further irritation of the psoriasis areas. So, psoriasis is more than just skin deep. Psoriasis not only affects the skin and cause agonizing joint pain, but it has the potential to cause severe social harm to developing preschoolers and school-age children. Because of this, psychological and social support is essential in the care plan of a child suffering from psoriasis. Children with psoriasis are often alienated, called names, teased, and bullied. Bullying has been shown to cause increases in anxiety, crying, panic attacks, sleeping problems, and a decrease in academic performance. Although psoriasis is not contagious, many children frequently experience discrimination at school or public facilities such as swimming pools. Children with severe psoriasis who experience these traumatic encounters can have long-term negative effects and are at increased risk for developing depression, anxiety, and suicidal tendencies in adulthood. Talk to the child. I would consider this primer intervention. Communication is very key. As healthcare providers, we must not only heal our patients physically, but we should also nourish them emotionally and socially as well. During a clinic visit, in addition to a routine skin assessment, the nurse should also evaluate the child's emotional state and overall quality of life. The nurse should interview both the child and parents and perform depression screenings. This can be done by utilizing screening tools such as the Child Depression Inventory, or CDI, also the Depression Scale for Children, also known as CESDC. Utilizing such tools will help evaluate behavioral changes, sleep quality, recent history of anxiety, increased crying, changes in self-esteem, and decreased academic performance, all of which are signs of possible emotional distress which may require further intervention. If needed, a referral to a pediatric mental health professional may be necessary. So, because of the social harm and emotional distress a child can experience, psychological and social support is essential in the care plan of a child suffering from psoriasis. A lack of knowledge and awareness is likely the driving force that causes discrimination. So, what can we do? Raise awareness. Increasing psoriasis awareness in the community, and especially those who surround the child, such as fellow classmates, teachers, and other parents, is especially important. Knowledge is power, and when people are educated and enlightened, positive behavioral changes may be manifested, and they are more likely to act with care, compassion, humility, and humility. This can also be considered a primary intervention, as well as it focuses on prevention. If we educate the people around us, they are less likely to initiate bullying. Use of technology. Another great way to raise awareness about psoriasis nowadays is to utilize technology and social media, such as Facebook, Instagram, Twitter, and YouTube. You can share and post psoriasis articles and links that explain symptoms of psoriasis, treatments, and also highlight the fact that psoriasis is, in fact, not contagious. Because young children with skin disease often live a buried life, either by their clothing or under bandages to hide their fragile medical conditions, it may be helpful for children to be around other children who face similar issues. Camp Wonder is a week-long summer camp held in Livermore, California, where children with chronic and life-threatening skin diseases from around the country take a break from being a patient and focus on just being a kid. They all share similar experiences about being bullied because they look different. Camp Wonder is a special place free of judgment, misunderstanding, and stares. It is an environment of acceptance and support to empower children to have fun, play, and just be themselves. I would consider this as a tertiary intervention, as the goal of Camp Wonder is to soften the emotional impact a child may experience living with a skin disease. So to conclude, psoriasis in young children is an under-recognized and misunderstood disease that can impair physical, social, and school functioning. It can add a significant psychological burden that has lifelong adverse impacts on self-esteem and mental health. Therapy goals in treating children with psoriasis not only includes the treatment of the skin, preventing further skin involvement, climate therapy, and topical therapy, but because of the associated emotional distress, psychological intervention and evaluation of how quality of life is impacted is critical. Empowering children to have a more positive body image is also vital. As healthcare providers, we must not only heal our patients physically, but we should also nourish them emotionally and socially as well. So that's all. Thank you everyone for listening. And these are my references. Again, thank you very much. Have a great day.